All right. Good afternoon, everyone. My name is Alexa Hawley, and I am a Partner Relations Coordinator for both the South and the West RPUs here at Care Compass Network. Welcome to today's Lunch and Learn. Today, we'll be discussing CCN's RTIC Pilot Implementation Program, providing hope and support through trauma-informed practices. Before we get started, I would like to go over a few housekeeping items. To help eliminate any background noise and to ensure that all attendees can hear the speakers, please keep yourself on mute. We do encourage you to turn your videos on. However, we understand if you're unable to do so. If you're experiencing any lagging or video quality issues, please try turning your camera off and then back on. However, if issues persist, please feel free to private chat Melissa Gussman. She'll be able to assist you. This Lunch and Learn will be recorded and be uploaded to CCN's website. At the end of the panel discussion, there will be a question and answer period. Please don't hesitate to place questions in the chat box throughout the presentation or during the question and answer period. The chat box is located at the bottom of your screen, as well as a raise your hand feature, which is located under reactions. At this point in the program, I would like to invite Georgia Entwistle, our Workforce Development Manager, to introduce our presenters. Georgia?
Thank you, Alexa. Bouakham Rosetti is the Senior Project Manager with Care Compass Network and also the Program Director for the CCN Regional Trauma-Informed Care Network, which was formed under her leadership in April 2019. Bouakham has accumulated over 12 years of meaningful experiences in behavioral health and primary care integration, practice transformations, business provider network development, project management, managed care, and quality incentive improvement programs. Bouakham is also the lead creator and developer of the CCN RTIC Trauma-Informed Care Pilot Framework and Program, which is being piloted across multiple care settings. She currently oversees and manages the implementation of 4 RTIC pilots, 2 school-based, a community-based, and a pediatric primary care clinic. In addition, she serves as the RTIC project manager for the Northeast Pediatrics and Adolescent Medicine site. Lauren Greco is a project manager with Care Compass Network and a certified associate in project management, which is a globally recognized credential from the Project Management Institute. In her last 4 years with Care Compass, Lauren has been intricately involved in the behavioral health landscape of the CCN region, championing the mental health first aid for first responders program and leading her team of instructors in certifying over 400 individuals to help address the need for behavioral health education in the region. Currently, Lauren serves as the project director for the HRSA Rural Health Network Planning Program, a federal planning grant that seeks to address critical gaps in behavioral health care coordination and crisis services in Shenango and Delaware County. Additionally, Lauren is a project manager for the RTIC Trauma-Informed Care school-based pilot program at Whitney Point, and the Training and Education Work Group Chair for Broome County Suicide Awareness for Everyone, BC Safe. Lauren continues to teach mental health first aid to the CCN partner communities several times per year. Emily Jones is a project manager with Care Compass Network and is also a certified associate in project management. Over the last 5 years with Care Compass, Emily's focus has been on working with social care providers throughout the region to address the social determinants of health needs to help close the gap of avoidable ED and inpatient care using evidence-based screenings and practices. In addition to her direct project work, Emily has been in several complementary roles, including serving as a network facilitator for CCN's cohort management program, as well as sharing her expertise as a certified Medicaid accelerated exchange facilitator through the New York State Department of Health. Currently, Emily serves as project manager for the RTIC Trauma-Informed Care Community-Based Organization Pilot Program at Mothers and Babies Perinatal Network and the school-based pilot program at Children's Home of Wyoming Conference. And Bouakham, I'm going to turn it over to you at this time.
All right. Thank you so much, Georgia, for inviting us. And thank you to all of you for joining us during your lunch hour. During our time together, our brief time together, we will provide a brief overview of our pilot program, focusing on the what, when, who, and how. Lastly, Emily, Lauren, and I will be sharing out some of the lessons learned, successes, stories, and transformations from the 4 pilot sites. For more in-depth pilot implementation work with the champions, please sign up for our 2nd annual Learning Symposium on October 14th. So with that in mind, let's get started. The CCN Regional Trauma Informed Care Network team. Here's the people I get to work with. And it is such an honor to represent our team today. I know there are some who are on this call as well. Our team was established in April of 2019, the CCN Regional Trauma Informed Care. We consisting of dedicated and passionate individuals, like ranging from colleges, healthcare, social care, human services, schools, and county government, spanning across CCN's 9 county region and beyond. We are also a proud member of the New York State Trauma Informed Care Network and have representation in the newly formed New York State Resilience Steering Committee. Despite the many challenges experienced by our team members, both personally and professionally, and as a community, our team continued to meet and forge ahead on the creation of the Resilience Resource Toolkit, Trauma-Informed Care Implementation Toolkit, hosting our annual Learning Symposium, collaborating with Binghamton University School of Nursing, and hosting multiple trainings, such as the 3-part DBT trainings. One of the best unexpected outcome was being able to support and comfort each other during these difficult times as a team. As a regional network, we value and support the implementation of trauma-informed care principles. We believe that by practicing these core principles, it takes into account a holistic person-centered approach that will eventually help to break the cycle of negative impact caused by trauma. A core strategy of bringing this to fruition is to create and promote access, availability of trainings, educational tools, and resources for our community. We, as a team, envision a resilient community that's built upon strong partnerships, trust, and compassion. Please take a moment to respond to our polling question. Do you and/or your organization, or have you or your organization implemented trauma-informed care? Okay, the results are coming in. All right, let's see. Yeses are like at 4, okay. Wow, all right, look, 45% said yes, 36 said no, 18% are thinking about it, which is really good. All right, so I think depending on where you're at, we can all agree that this is hard work and it requires a significant amount of effort, intentionality, planning, resource allocation, trainings, and a change in cultural and mindset of all involved. So the road to trauma-informed care. Trauma-informed care is a strengths-based framework which recognizes the complex nature and effects of trauma on individuals and promotes resilience and healing. It's about asking what's happened to a person and not what's wrong with them. To support framework creation, we look to SAMHSA's 6 guiding principles of trauma-informed care approaches, which are safety, trustworthiness, and transparency, peer support, collaboration, empowerment, and cultural, historical, and gender issues. Each of our 4 pilots are empowered to use this as a guide to supporting their work at the ground level. You will see in the pilot report out how some of our teams have been able to accomplish this. It is important to note that adopting and implementing a trauma-informed care approach or response is not achieved through any single checklist, approach, or technique. Rather, this process of transformation requires continual commitment, attention, caring awareness, sensitivity, intentionality, continuous quality improvement, engagement of stakeholders, and cultural change at the organizational level. Always start small. So here's our RTIC framework. Here's a brief summary of our pilot summary. It's an 11 to 12 month program with the goal of supporting the CIT, which stands for Core Implementation Team, and organization as they work on creating an environment that is safe and healing for both staff and individuals they serve. Each pilot is assigned a dedicated RTIC CCN project manager to support the implementation efforts. Our pilot will focus on 4 key priorities: training, screening, collaborations, and transformation. These will be further drilled down in the milestones and deliverables in the how section of our slide. What does transformation look like? Here are some of the common themes that were reported as part and shared as part of their vision at for our 4 pilot sites. Common themes include staff and organization will be better informed, more knowledgeable, safer environment, supportive system, be more aware of our own triggers, resilience, change in processes and approaches. All these requires a commitment to educating and training of the team to better support this new transformation. So you might ask, why? Why are you doing this now, right? I mean, of all the times, why? So much has changed with COVID. Every one of us has been impacted in some way, shape, or form. The significant increase in mental health struggles, social isolation, grief, loneliness, suicide, losses for our children and families has been staggering. Teachers, educators, healthcare professionals, providers, frontline staff are experiencing an unprecedented level of stress, burnout, and moral injury. These challenges requires all of us to care for one another and to create an environment that promotes resilience, safety, and support. I feel almost everyone is familiar with the saying, "Don't or put on your own oxygen mask first" concept from the airlines. This is so true. This applies in everyday scenario and not just during a crisis. Please remember that we can't expect our staff to be their best self or to be operating at the top of their game if they don't feel well, supported, and valued. We can't keep on putting Band-Aids on these shortcomings. Tell our staff to practice more resiliency, deploy more coping skills or self-care without looking to change the system itself that may be contributing or causing those risk factors for our teams, staff, and community. Remember to involve your staff in the process as much as possible. Our pilot program is needed more now than ever. It is intended to provide both the staff and leadership the framework to create a safer and resilient environment, while at the same time, equipping them with some skills and trainings to adopt and support those they serve. So the who. I am so honored and proud to highlight the core implementation team members of our pilots, our 4 pilots. The Children's Home and Whitney Point began their trauma-informed care journey in April of 2021. Here's a list of the individuals and their roles. Northeast Pediatrics and Mothers and Babies began their journey in May of 2021. Take a close look at the team, their staff, and their roles. When selecting your CIT team, consider having 5 to 6 core team members and bringing on additional team members as needed. The CIT team is truly the champion, driver of innovations. They're the cheerleader and the glue that holds the pilot work together. They meet to assess, plan, troubleshoot, and monitor the pilot transformation and milestones. The how. Here is an overview of our pilot framework and program consisting of 5 to 6 milestones with deliverables outlined. This work is supported by other documents such as the pilot framework summary, funding milestone distribution, and trauma-informed care toolkits. It provides the team with a structured framework, but is highly dynamic and agile, meaning we encourage the CIT team to provide input, knowledge, and alignment to their current programs to optimize implementation, outcomes, and sustainability. One of the most important aspects of a successful transformation or implementation is building awareness in your staff and team of the why. This will help them to understand the importance of the work that you are embarking on, generate buy-in, collaboration, and engagement at all levels. Milestone 1 is intended to provide the structure for the CIT team to come together, collaborate, and also learn about what, which is trauma-informed care, right? So they can lead as a team. Two of the biggest identified challenges are time and resource allocation. Those will exist regardless of what new initiatives we decide to take on. It is important to note that all of the pilots continue to express how meaningful this work has been at the ground level and are still committed to moving forward due to the benefits and value trauma-informed care will have or has had on their staff and individuals they serve. Here are the additional milestone pilots that our CIT team will be working on through the development of their 3 action plans for milestone 1. And so naturally, all of them are working towards completing the rest of the milestones. Here's an example of the how for milestone 3, the screening process, right? And some of the steps and questions to assist the CIT team as they work on the screening process. For example, Northeast Pediatrics team form a screening provider research team to help direct and guide this process. This is one of their action plan for milestone 1 that they're working on. Another example is the children's home. They're exploring using the CAN screening. Here's our sample of our key pilot dates, deliverables, and timeline. As you can see, it is a very aggressive timeline, but it's intended to keep the momentum going. Key success factors. These weekly and monthly touch points are intended to create the safe space and time to support the ongoing communication and planning efforts. It is still the responsibility of the CIT team to closely monitor, plan, review within their own organization. Our progress to date. So as you can see, the numbers of trainings that have been completed in less than 5 months, over 300 completed trainings so far. This is a huge accomplishment and success across the 4 pilots. Remember, the 2 school pilots started in April, and then CBO and our primary care started in May. Here's our average training evaluation score. As part of that process, we also collect how impactful these trainings were to the staff. I'm happy to report that all of the trainings so far have been extremely positive. The average score is 4 or higher. This is based on the rating scale of 1 being least effective to 5 being most effective. So I want to do a shout out and kudos to the RTIC team who participated in the research evaluation of all these pilot trainings. Thank you from the bottom of my heart. Great job, team. Here's several training feedbacks that we have received on some of the trainings that they took. And we provided this just to basically give you a sense of the essence of why we are doing the work that we're doing. The unexpected outcome was that many of the staff actually wanted more trainings. They wanted more resiliency training, more mindfulness training, and more practical application and tools. Our RTIC pilots report out. Now I would like to warm hand off to Emily Jones, who's our RTIC project manager for the Children's Home and Mothers and Babies.
Thanks, Bouakham. Hi, everybody. Next slide, please. Thank you. So the Children's Home of Wyoming Conference Center has been serving children and their families for over 109 years with 6 locations throughout the region. The Children's Home is a licensed New York State Education Department to provide specialized learning services in an on-campus school setting for children. So for the pilot site, they are looking at their school-based programs, specifically the middle school program, which is comprised of 4 teachers and 19 students. With incorporating trauma-informed care practices, students will be in an environment that is trauma responsive and more relational, allowing them to thrive emotionally so that they can focus on learning while staff also gain confidence in their skills as they become more knowledgeable in trauma-informed care. And also, more importantly, is incorporating those self-care practices for the teachers. Next slide, please. So some high-level successes. There's so many, but we condensed it down into a slide. I just want to highlight a couple of things. The language of trauma-informed care is becoming infused in everyday practice for the Children's Home, and students are really starting to recognize that, as well as the teachers. And with all the trainings that Bouakham highlighted in the previous slides, staff are able to identify areas where they can grow in, use for themselves, and when teaching the students, and also overall learning more about trauma-informed care. Next slide, please. One big transformational change that Children's Home has discovered is adding the short videos from the toolkit. So each pilot has a trauma-informed care toolkit that goes along with the pilot. And the staff were so responsive to the trainings that they really wanted to incorporate them more in their staff meetings. So this just, again, further promotes trauma-informed mindsets. Next slide, please. So with success, there's always going to be lessons learned. And of course, it being a pilot, it's also going to have its lessons learned. So a couple of high-level things that are to share with you today is that mindsets can be really hard to shift, but they can be shifted. And that happens with the core implementation team. So with the Children's Home, they've had that core implementation team be able to rally behind the intention of trauma-informed care and therefore move it through the organization. Another thing that is helpful is they started in the summer, which was helpful before the school year. So it felt more natural to the team and to the teachers that are doing the trainings. And then lastly, you always need a backup plan. I think everyone can relate to that. So next slide, please. One barrier that led to a greater change was looking at the scale. So Children's Home started out with 2 pilot sites, the middle school program and the day program. And they really looked at how can they implement this in a meaningful way. So what they did is they narrowed the scope to just the middle school program. However, the teachers and staff in the day program are continuing to be trained and continuing to learn about trauma-informed care, but the students will be screened in the middle school program. Next slide, please. Oh, Mothers and Babies. So Mothers and Babies Perinatal Network is located in Broome County, but serves clients in 8 counties throughout the region, with 5 service lines to improve pregnancy and birth outcomes, as well as supporting the health and development of all individuals and families. For their pilot site, Mothers and Babies is focused on staff having a greater understanding of the impact of trauma on the clients that they serve, utilizing trauma-informed screening tools to assess needs and provide follow-up care, as well as engaging staff in self-care practices they can incorporate in everyday lives. Next slide. So similar, you can kind of see the pattern here, successes and transformations. You know, similar to Children's Home, they really are utilizing the core implementation team to implement and share the lift of engaging the staff with trauma-informed care. They are utilizing staff meetings to do the trainings. And then lastly, the trust assessment, which was one of the required steps in milestone 1, really helped them develop the action plans that they need to set forth to implement the program. Next slide, please. Some lessons learned. The time and dedication needed. You know, it is something that is, you need that time and dedication, but they are working through that and seeing, you know, what works and what doesn't work. And it will always be a fluid process when building a trauma-informed care environment. Next slide. So one really cool success story that they would like to share is they did a self-care and sort of, you know, having the staff let their hair down a little bit and not be in the office. And that really promoted staff to talk to each other, build relationships, relax, focus on self-care, and reflect on who they are as people and their work. This happened in June, and they're really looking at incorporating more days like that based on the staff's response. Next slide. So I'd like to hand it to my colleague, Lauren. So Lauren, take it away.
Thanks, Emily, and hi, everyone. As Bouakham and Emily have highlighted earlier in the presentation, the increase in social isolation, loss and burnout, and mental health challenges resulting from the COVID-19 pandemic have made the implementation of trauma-informed care programs more critical than ever. Despite these challenges, or rather in support of proactively hedging against these challenges, Whitney Point has moved forward with the trauma-informed care school-based pilot program with great intention. For their pilot site, the Whitney Point team selected Carol E. Adams Elementary School, which includes approximately 92 staff members and 482 students, grades early kindergarten through 3rd grade. Whitney Point's core implementation team has been working diligently through the first phases of the pilot program, including the addition of summer meetings to work through their training and screening action plans and to prepare for overall program launch this fall. Next slide, please. So the Whitney Point team has realized early successes, which has helped the momentum to grow. Because the core implementation team has been able to align the milestones of the trauma-informed care pilot program within the context of existing district programs and processes, the Board of Education, teachers, and staff have largely expressed support of the trauma-informed care approach. The district as a whole has started to recognize the complementary capacity of trauma-informed care principles to the district mission and vision. They realized that they didn't need to reinvent the wheel, but could align their pilot work with their current programs and initiatives to become stronger overall. As an example, the trauma-informed care pilot program directly supports their work as a community school and has been tailored to include educational initiatives such as the Incredible Years Dinosaur classroom curriculum with the intention of aligning with existing initiatives. Like any pilot program, the Whitney Point implementation has not been without challenges, including two very common considerations, which Bouakham mentioned earlier, time and resources. With the pilot launch in early April, the team was challenged to complete the startup phase, develop a plan for summer, and establish the fall rollout, all within the first few months, at the same time as they were trying to understand the program and complete the required trainings. Additionally, there were heavy staffing changes, including the retirement of the district superintendent and the CEA school principal, and the resulting onboarding of a new assistant superintendent, a new school principal, as well as a new school counselor. While these changes have proved to be very positive, it did necessitate an extra phase of onboarding, which added time to the process overall. Next slide, please. In terms of lessons learned, the Whitney Point team had realized that many of the elements of the pilot program, especially in the realm of training, have been attempted in the past, but have not necessarily been supported or sustained through a structured strategic plan or workflow. The team sees the pilot program as providing the trauma-informed care framework for the future to allow sustainability as well as evolution over time. As previously mentioned, the first few months of the program tasked the core implementation team with a heavy load of deliverables, and they were required to take training while simultaneously establishing regular meeting schedule, building their team, conducting organizational assessments, building their project charter, action planning, and defining metrics. In hindsight, the team would have liked to take the core trainings first and then move on to the next phase. But they still wouldn't have had enough time because that's just always the way it goes. But next slide, please. And then in terms of unexpected outcomes, the Whitney Point core implementation team had been pleasantly surprised to see how their work has been received across the school community. The health and wellness of students and staff continues to be top of mind for this team as they head into the new school year in a few short weeks. As a priority for this new year, the core implementation team wants to ensure that their teachers and staff feel supported, heard, and validated, not just as employees of the district supporting students, but as individuals who might be struggling to support their families and themselves through these trying times. In support of this, Whitney Point has planned a restorative practices session for all pilot staff on September 8th. This learning opportunity will give teachers and staff concrete tools for wellness, as well as strategies for sustaining this in the long term. And I will hand it back over to Bouakham.
All right, I might want to unmute myself. Thank you so much, Lauren. Great updates and presentation, Emily and Lauren. I would also like to report out to all of you that all 4 of our pilot sites have completed their milestone 1 successfully. Our pilot site, Northeast Pediatric, is located on Graham Road in Ithaca, New York, consisting of 44 staff serving patients' families from ages 0 to 21 years of age. Honestly, supporting and working alongside the Northeast Core implementation team has truly been inspirational. Have there been barriers and challenges? The answer would be yes. I can list them out: time, limited staff resources, COVID, vaccination clinic, 15-minute appointments, sick appointments, staff turnovers, patient in a crisis. These are inherent obstacles which the CIT team has been able to successfully navigate and develop an actionable working plan to move the pilot forward. So that's why we are seeing these successes. One of the biggest success is the EAP counseling contract that went live as of this month, August 1st, 2021. That means all 44 of Northeast Pediatric staff and their loved ones and significant others are able to receive these much needed mental health services. And that is part of their one of their action plan and tasks that they were able to complete much earlier than anticipated, because an action plan should be able to be implemented between 1 to 2 months, or should be actionable. We have been able to accomplish so much in a short period of time. This could not have happened without great intentionality, effort of planning and coordination from the CIT team. They come prepared to the CIT weekly touch point, reporting out on their action plans, brainstorming, troubleshooting, and defining next steps to keep the work moving forward. Here are some of our lessons learned. Planning is key, and being intentional is critical to ensure it does not impact patient care and staff negatively. We review and map out the next 2 to 4 months of trainings to maximize staff's time and needs, because all of you know a primary care clinic, well visits, right? It's booked a year in advance, and there's always sick children to tend to. It's definitely been a balancing act. For example, as noted, it took more time than anticipated to pick the 3 action plans. Their challenge was balancing what the small CIT team versus generating or getting an input from all of their staff. However, I have an asterisk there is because we would like to highlight that the staff with more lived experiences of trauma are advocating for more staff involvement, which is a great thing. However, it does slow the whole process of implementation down. But we are hoping that this will lead to more meaningful changes. This was both a lesson learned and also success for us as a team, since the staff from all across the organization are involved and they feel safe providing feedback on the process. Here's one of our unexpected outcomes. So over the past week, Dr. Jessica Connor, who is our champion, and she is the Director of Behavioral Health Services at Northeast. So she had conversations with 3 providers and 1 medical assistant that they initiated regarding ways in which trauma is influencing their presenting concerns and well-being. So of those, 1 was able to identify that the family should be connected to a BHC via a warm handoff. And the other provider identified that by providing validation in the moment with the families and the patients was so powerful. This work is possible. It's small incremental changes. Our team had under their belt with this unexpected outcome was the CTAC training, completion of the CTAC training, and the RTIC Project Teach Trauma-Informed Care Modules 1, 2, and 3. This is what investing and prioritizing trainings can do for your team. Here's an example of what Northeast social media and communication to their patients, families, and community. Sharing the why is a critical piece of that milestone 1, which is a startup funding milestone. It helps to set the tone and expectation. The clinic closed their office down for half the day to support trauma-informed care training, modules 1 and 2. Being fully transparent also sends a powerful message to the staff and patients and families that this is a key priority. It basically sends the message of all hands on deck. Here's our success story. Since beginning this project, we have had many staff starting to open up with peers in appropriate ways and challenges that they have been through and strategies that have promoted resilience. It has been really powerful to watch. This is the type of transformation that we want to see, which literally gives me goosebumps. These are the results, engagement of staff who feel empowered and supported. These successes can and will serve as that guiding light for the team, promote bonding, connectiveness, and strengthen relationships. Trauma-informed care is relationship-based. So with that in mind, I would like to encourage all of you to take a moment to respond to this polling question. So after hearing about our work do you feel or your organization or community would benefit from trauma-informed care adoption or lane? Wow, okay, 100% of you. So we don't even need to go on. All right. Wow, thank you so much. All right. Okay, so 100% of all the individuals on this call believe in trauma-informed care or its values. And so I just want to basically let you know that trauma-informed care, implementation and adoption, it doesn't have to be a burden. It can simply start with just one core training that you launch or offer with your department or your team. We have also provided at the end of this slide deck a listing of some tools and resources for you to use. We would like to end with sharing this powerful quote. Trauma is personal. It does not disappear if it is not validated. When it is ignored or invalidated, the silent screams continue internally, heard only by the one held captive. When someone enters the pain and hears the screams, healing can begin. Here's what we know. 1, we as human beings are hardwired to connect. 2, having one positive adult, supportive mentor relationship can make a world of difference for a child and an adult. Children, 3, children are resilient with adequate support from a caring adult. That could be teachers, caregivers, parents, grandparents, coaches, primary care team, neighbors. Ultimately, supportive relationships, communities help individuals who have experienced trauma and ACEs to better cope and heal. Thank you so very much for your time today. And we will move on to the question section of our presentation, if there are any.
Thank you so much, Bouakham, Emily, and Lauren. If there are any questions, just place them in the chat box. And if not, then we can continue on with the presentation. I'll just give it a couple minutes.
No questions? All right, so let's continue on. We've listed in our power presentation some upcoming events, and really looking at how can we support you at the ground level with these key training initiatives and empowerment. So on September 23rd, we are bringing leadership and supervisory way of being that supports and guides trauma responsive environments. And everything's free. It's open to the community and region and even New York State wide as well. There is a max capacity, so please register early. Second is our second annual learning symposium, which is taking place on October 14th, consisting of 5 workshops. And please feel free to register. And that one will really focus on impacts on such as secondary trauma, VT, self-care tools and strategies. And at this session, you'll be hearing directly from the champions at the pilot site about all of their progress to date. And here are some tools and trainings to get you started with links to consider. And we would also, we also included some feet on the floor, the grounding technique for you to deploy, try out with your team or with yourself. So again, anything is possible. Together, anything is possible. So thank you so much for all of your time. And
Bouakham, there was a question placed in the chat box.
Oh, there is, okay.
Yep, it says, has there been any thought of trying to include law enforcement?
Yes, certainly. We have definitely tried to incorporate that as much as possible. Actually, Karen Roseman and I created, in collaboration with some of the lieutenants at Broome County Police Department, a trauma-informed care / de-escalation training. So that went extremely well. I think, you know, the challenges that we run into is the readiness, right? The availability of resources and time on the part of the organization themselves, and what is, you know, going on currently. But I would love, if you know of anybody, Polly, send them our way. We'd be happy to talk.